better sleep, sharper focus, a healthier life. It all starts with how you breathe.
Welcome to the No One Told Me, the Airway Health Connection, the Untethered Way, where better breathing meets better living. I'm Dr. Meggie Graham.
I'm Dr. Liz Turner.
We're the co-founders of Untethered Airway Health Center,
on a mission to help you breathe freely and live fully through proactive airway health.
Whether you're a dentist expanding your airway expertise,
or a family looking to sleep and breathe easier,
you're in the right place.
Each week, we'll bring you bold insights, real-world stories, and expert tips.
All to help you take control of your airway health. Because when you breathe better, you live better. Let's get started.
Hi, everybody. Welcome back. I'm Meggie Graham. Today's episode is specifically for dentists. What I want to talk to you about is how do you become airway aware? We are seeing patients every single day, and we can start to notice patterns and signs that there's airway dysfunction without needing to buy any sort of equipment, without needing to change how we're treating patients, just looking at things a little bit differently. And I want to talk about all of the things that you're likely already doing that are giving you clues or could be giving you clues that your patient is struggling to breathe or has airway dysfunction, which is increasing their dental risk, increasing the failure of your restorative work, and it having a negative impact on their systemic health. We all have patients fill out health histories. When you start to see the red flags, you're going to start to see them repetitively in groups on your airway patients. What I mean by that, patients that have had airway dysfunction for a lifetime often will say that they have problems sleeping, often have respiratory issues like asthma, chronic congestion, allergies. They may be aware that they're mouth breathing. They may say that they snore. Perhaps they have a diagnosis of obstructive sleep apnea. Those are obvious ones, right? Patients that have airway dysfunction often also have a history of depression, anxiety, neck tension, headaches. They will have a higher likelihood of having cardiovascular disease or hypertension. They're also more likely to have hormonal imbalances. You don't need to become an expert in how it connects to all of these. We can get into the weeds and talk about each one of them at some point, and I'm more than happy to do a podcast episode on that. But right now, I just want you to become familiar with the grouping of certain symptoms of airway dysfunction that are showing up as line items on a health history or when you're taking a patient interview. In a dental history, they might have a history of bicuspid extractions. They might have a history of attrition or repetitive failed dentistry. They might have multiple cracked teeth or teeth that have been cracked and crowned and root canaled and then extracted. So looking for a pattern of consistent failure of dentistry, not just rampant recurrent decay that's been left untreated. Okay, so those are things that you can look for in the health history, the dental history, before the patient even gets to the office. Now, of course, that's not a diagnosis, but it's a red flag. And what I want to do right now is just create airway awareness. Before you can learn to treat differently or add treatment modalities in your practice, before you can learn how to build an interdisciplinary team or make appropriate referrals, you have to know how to identify these things in patients, okay? So we're already doing a health history. Nothing has changed. You're just looking at the health history different. If it's a pediatric patient, or depending on what your adult paperwork looks like, it might be that they had a history of feeding issues as a child. Maybe they were a picky eater, or they gag frequently. They were unable to nurse. Not one of these things is a diagnosis, but they're all clues, and you'll start to notice them lumped together. Once the patient gets to the office, you can start your exam before they're even in your chair. So depending on the workflow of your office and how they come in, you as the provider might have the opportunity to see them in a standing position. If you do, you're going to start to notice long, narrow faces, perhaps malocclusions. Either they're going to have a jet forward underbite or they're going to have a long, narrow bite. You will probably see a forward head posture. If you're unable to breathe, your body is so great at compensating, that one of the things it will do is slightly jut your head forward to create more opening in your airway. And patients do that without any awareness to it. Again, a forward head posture is not a diagnosis of an airway issue, but it's a red flag. So pay attention to that. Look at their face. Do you notice excessive venous pooling or dark circles under their eyes? Do you notice that they show an excessive amount of sclera underneath the pupils in their eyes? Do you notice chapped lips or parted lips? Do you notice that there is mentalis strain or orange peel dimpling on their chin when they swallow? Okay, these are all things you can glance at a patient and notice. Now, let's say the patient's in your chair. These are things that you could notice while you're doing your normal hygiene exam, or you might notice before you do a restoration when you just start to look in the mouth. We're all doing or should be doing oral cancer screenings biannually or at every hygiene visit. It's the same thing. You're just going to look at it a little bit differently. So we look at soft tissue. We look at bony tissue. We look at teeth. So let's talk about the things that you might notice when you're looking in the mouth that could be an aha moment or something to dive deeper into. So once you're looking in the mouth, these are the things that you can start to look for. Do they have severe attrition? Is there a generalized flattening across the enamel? Do they have erosion? Now we think of erosion or acid wear on the teeth to be from lemons, bulimia, vomiting, soda. And of course, those are things that can cause acidic erosion on enamel. But laryngeal, pharyngeal, or respiratory reflux is also something that causes erosion over a lifetime. GERD is also associated with erosion. So start to look for signs of acid wear. Do they have a history of repetitive dental failure, dental restorative failure? And what I mean by that is, do they have a mouthful of restorations that look like they have been done and redone? You can picture this. There's a crown, and through the crown, there's a root canal access opening plugged in. Do they have multiple root canals? Do they have multiple crowns that are fractured? Do they have teeth that have big fracture lines? So looking at the teeth, again, restorative failure or dentition failure is not on its own an airway diagnosis, but it is something to look at and be aware of and check it on your box. Looking at soft tissue, look at the tongue. Does the tongue have a short lingual frenum? Are they able to elevate their tongue to the roof of their mouth? What does the opening to the oropharynx look like? Is it erythematous? Is it red? Can you see the tonsils? Are they large? Are they touching? Does the uvula look like it's really long, like somebody hung on it and it's pulled down? Does the soft palate drape so that you can't even see the opening into the airway? What about the roof of the mouth? The roof of the mouth could be narrow and vaulted and not flat and wide. Those are signs that the growth was altered and the airway is altered. So far, everything that I've mentioned is a red flag for potential airway dysfunction. And so far, everything that I've mentioned is something that you can see without changing a thing or buying anything special. On the tongue, you might also notice scalloped edges. So when they stick their tongue out or open their mouth, do the edges of the tongue look wavy? Do they look like the edges of a Ruffles potato chip? That means that their tongue is squished into a house that's too small, is low tone, and not sitting on the roof of the mouth. That means that their muscle function is altered, which could have led to altered growth and development of the skeleton. One of the things that I'll often do is during an exam, I'll say, you know what, I've been in there a long time. Go ahead and take a break and go ahead and rest your mouth and swallow. I don't want to give them specific instructions about swallowing. I just want to see how they swallow. When they close their mouth and swallow, do you see tons of muscle activity on their orbicularis oris and their extraoral muscles? Or do you see them gently close their mouth and then maybe you see just the tongue move underneath their mouth? If you see a ton of activity, a ton of muscle activity, that's a red flag for muscle dysfunction that has probably led to altered development of the skeleton and means that they probably have a higher risk for breathing dysfunction. So for example, if you're watching this rather than just listening to it, when I am swallowing with using my extraoral muscles, you're going to see a lot of puckering around my mouth. And that's me using outside muscles to try to create a seal to swallow. When I use my tongue and swallow, all you'll see is my lips close, and then you'll see a little bit of movement underneath my chin. That is the proper way to swallow. And so again, you don't want to create a lot of awareness so that patients alter their normal function. You just ask them to close and swallow and see what you notice. All of these things are exactly what you're doing every day, or maybe a slight tweak to what you're doing every single day. And this is starting to notice patterns. And challenge yourself for the next month or two to do exams this way and just make some notes. What do you notice? Do you start to see that patients that have all of those red flags that I listed on the health history showing up with some of the physical red flags that I just mentioned in the exam? This is pattern recognition, and this is going to be the very first step to becoming airway aware. I want to take just a couple of minutes for the providers that are treating pediatric patients on things that might be red flags in their health histories or things that you might see in their oral cavity that differ slightly than adults. In a pediatric patient, you might see on their health history nocturnal enuresis or bedwetting past the age of potty training. You might see that they have a diagnosis of ADHD or behavioral issues. You might also see that they have asthma or recurrent respiratory infection. You might see that they have chronic daytime sleepiness or hyperactivity. Those are things that jump out to me as a potential for an airway risk factor. In a child, it's very easy to see excessive attrition early because of the enamel being so thin that they might wear through their enamel and have dentinal exposure. So that's something to look for in a child as well. So hopefully you're leaving today's episode with some checklists that you can take into your practice tomorrow or Monday or whenever you go back. And I want you to do your exams and look at your patients with a slightly different lens and just become curious on your path to becoming airway aware. Thanks so much for being here.
Thanks for tuning in to the Untethered Airway podcast.
If today's episode helped you see things differently,
Please share it with someone who would benefit from hearing this. And don't forget to subscribe.
want to learn more about airway health or connect with our team?
Please visit our website, untetherediairwayhealthcenter.com, or follow us on Instagram @untetheredairway.
Until next time, bye.